Hello dear students, today we are discussing the transient tachypnea of newborn or TTN. The case is a classic exam vignette, a 38-week term male infant delivered by elective cesarean section with no preceding labor, who develops tachypnea within the first few hours of life, and this pattern strongly suggests towards the TTN. The baby initially looks well with APGAR scores of 8 and 9, so there is no major birth asphyxia. As at 2 hours of life, he develops respiratory rate of 85 per minute with mild intercostal retractions and intermittent grunting. Oxygen saturation is mildly low, that is the 92% on room air. But temperature is normal, breath sounds are clear, and there is no murmur. This tells us the respiratory distress is mild to moderate and likely pulmonary rather than the cardiac or septic. The diagnosis is transient tachypnea of newborn. The word transient is important because this condition usually improves spontaneously within 24 to 72 hours of life, and the main problem is not immature lungs or absent surfactant. The main problem is that the lungs are still filled with excess fetal lung fluid. In fetal life, the lungs actively secrete fluid. After birth, this fluid must be rapidly absorbed so that air can enter the alveoli and diffuse into the circulation. During normal labor, a catecholamine surge activates epithelial sodium channels on the alveoli of the lung. Sodium moves from the alveolar space into the interstitium and water follows the sodium. This clears the fetal lung fluid. But in elective cesarean section without labor, this catecholamine surge is reduced. So fluid clearance is delayed and baby develops wet lungs, leading to the tachypnea. Now come to the MCQs. What is the primary pathophysiological mechanism responsible for the patient's current condition? Option A. Quantitative and qualitative deficiency of pulmonary surfactant. It is incorrect because this describes the neonatal respiratory syndrome and it is seen in preterm infants. It causes the reduced lung compliance and treatment include oxygen support and use of surfactant therapy. Option B is the correct answer. Delayed clearance and absorption of fetal alveolar fluid. Option C, in utero aspiration of meconium stained amniotic fluid. It is incorrect because meconium aspiration usually occurs in term or post-term infants with fetal distress and meconium and history of meconium stained liquor. And in these cases, chest X-ray often shows patchy asymmetric infiltrates and hyperinflation. Option D, failure of normal fetal to neonatal circulation transition. It suggests persistent pulmonary hypertension of newborn. Persistent pulmonary hypertension of newborn. And that is usually present with more severe hypoxemia and cyanosis. Option E, congenital hypoplasia of left lung. It would cause persistent structural respiratory problem but not a self-limited tachypnea after C-section. So it not resolved by its own as the TTN. Now come to the next question. The point of care lung ultrasound demonstrate multiple vertical echogenic artifacts or B lines extending from the pleural line. What do these artifacts represent in this specific clinical context? So this is the pleural line and these are the vertical B lines. In TTN, B lines represent excess fluid in the interstitial and alveolar compartments. So they are suggestive of fluid in the interstitium and alveoli. So the correct answer is C, interstitial and alveolar fluid accumulation. Now let's see other options also. Option A, alveolar consolidation and complete loss of aeration is incorrect because consolidation gives tissue-like lung pattern and sometimes with air bronchograms as seen in pneumonia. Option B, air in the pleural space means pneumothorax. Pneumothorax usually shows absent lung sliding and A lines. Option D, massive exudative pleural effusion is incorrect. Pleural effusion appears as an anechoic or hypoechoic fluid collection, not the vertical B lines. So in this case, anechoic or hypoechoic shadow will be seen. Option E, normal reverberation artifacts of a fully aerated lung. It is also incorrect. A fully aerated lung usually show A lines and not multiple B lines. So the option C is the correct answer. Now come to the next question. Which of the following factors in this patient's history most significantly increase the risk of developing this condition? The most important risk factor here is the history of cesarean section without prior labor, because labor is necessary for the catecholamine surge that helps in the clearance of the fluid from the lungs. So the answer is B, delivery via the cesarean section without prior labor. Other options, option A, mother's gravidity and parity is irrelevant. G2P1 does not significantly increase TTN risk. Option C, gestational age of 38 weeks is not the best answer because TTN can occur in term or near term infants, but the strongest clue is elective cesarean section without labor. Option D, intraamniotic infection would suggest neonatal pneumonia or sepsis, but the case has no maternal fever, no neonatal fever, and no specific appearance. So option D is also incorrect. Option E, APGAR score of 8 at 1 minute is not concerning because this is a good APGAR score and does not explain the tachypnea. Now come to the next question. If a standard anterior-posterior chest radiograph were obtained instead of an ultrasound, which of the following findings would most likely to be observed? So let's see each and every option. Option A, diffuse fine reticulogranular ground glass opacities with air bronchograms. It is classically seen in cases of neonatal respiratory distress syndrome. Ground glassing opacities with fine reticulogranular pattern, and they are present diffusely in both lungs. Option B, patchy asymmetrical infiltrates with severe hyperinflation. Patchy infiltrates with hyperinflation is suggestive of meconium aspiration syndrome, not the TTN. Option C, prominent perihilar linear streaking and fluid within the interlobar fissures. Yes, it is a correct answer. It is a sign of TTN. Option D, a localized lobar consolidation with associated paraneumotic effusion. It is also wrong. It is seen in pneumonia with effusion. Option E, the Sale sign. Sale sign is the normal neonatal thymus. It is not the cause of respiratory distress. Now come to the next question. What is the most appropriate next step in the management of this infant? The management of TTN is usually supportive care with monitoring and oxygen support as per need. Sometimes when there is increased work of breathing, then in those cases nasal CPAP can be used and feeding support should be continued. It is usually resolved within 1 to 3 days without any sequelae. So only the supportive care is required. So the option D among these all options is the correct. Let's see other options also. Option A, immediate surfactant therapy. It is incorrect. It is the treatment for the neonatal respiratory distress syndrome, not for the TTN. IV ampicillin and gentamicin. It is required for the neonatal sepsis or pneumonia if suspected. So this is also not a correct answer. Option C, prompt endotracheal intubation and mechanical ventilation. It is unnecessary unless the baby develops severe respiratory failure, so it is not the correct option. Option E, administration of inhaled nitric oxide. Inhaled nitric oxide is used in the treatment of persistent pulmonary hypertension of newborn. What are the take-home messages? Classical TTN presents in near-term or term infant who born via the elective caesarean section without labor, and it presents with tachypnea within the first few hours of life. It usually resolves spontaneously within 1 to 3 days with minimal supportive care, and its pathophysiology includes the delayed clearance of fetal alveolar fluid due to absent labor-induced catecholamine surge, which is the most important aspect of the pathophysiology of TTN. The lung ultrasound will show the confluent B lines and double lung point. Double lung point is the abrupt transition between a normal upper lung field and a B-line rich lower lung field on USG, reflecting the uneven retention of the fetal lung fluid in TTN. It is the characteristic sign of TTN. Chest X-ray shows the perihilar streaking and fluid in the fissures. Management is supportive care with oxygen support and sometimes CPAP support. It resolves spontaneously within 1 to 3 days. However, its differentiation from other diagnoses is also very important. So this is all for today. Thank you.